Good afternoon. This is Genevieve Kenny, an Institute Fellow in the Urban Institute's Health Policy Division. I am a woman of a certain age with silver hair and glasses. I'm wearing a blue shirt, navy blue shirt, and a cream-colored sweater. I'm delighted to welcome you today to this convening where we're spotlighting the role that community engagement has played in shaping and guiding our research on access to health care among people with disabilities. Next slide. This research was done under a grant supported by the Robert Wood Johnson Foundation that focuses on Medicaid and equity, and that includes a community advisory board. Our community advisory board, next slide. Back up, please. To the next slide, please. No, it should be the slide that has the housekeeping. I'm sorry. Sorry about that. Our community advisory board comprises 10 members who hail from different parts of the country, all of whom have direct experience with the Medicaid program. Next slide. Yes, this slide. Before providing more information on the session, I wanted to cover a few housekeeping items. We've provided ASL translations and CART captioning, but my understanding is that we need to start this session without the interpreters because of some technical issues we're experiencing, and I apologize for that. They will be on board as soon as possible. The event is being recorded, and the recording will be posted online afterward. Speaker biographies and related materials are available online as well. All participants are muted, but you can type your questions or comments into the Q&A box at any time. Next slide. We have a great lineup for you today. After introductory remarks from Miriam Hernandez and myself, Dr. Kima Joy Taylor from Anka Consulting will moderate a discussion with Urban Institute researcher Dulce Gonzalez and Crystal Evans and Charisse Rhodes, who are members of our Community Advisory Board. That will be followed by reflections from Mia Ives-Ruble from the Center for American Progress, who will touch on the federal Medicaid funding cuts that are being considered on the Hill, which I'm guessing are very much front of mind for many people at the moment. And also from Noelle Sanders, a longtime member of our CAB, who's going to speak to next steps she thinks are important to address that would reduce or mitigate problems with how research on people with disabilities is conducted and how it's released. We'll then take questions from the audience or address questions that have been shared from folks who are participating. And Kathy Hempstead, Senior Program Officer at the Robert Wood Johnson Foundation, will share some thoughts to close the session. We are so appreciative to Robert Wood Johnson Foundation for supporting a community advisory board, which has been invaluable in allowing us to bring Medicaid enrollee voice to our work. The Community Advisory Board was, next slide, slide before is perfect. The Community Advisory Board was part of the project from the beginning so that our research would be informed by the insights of people with direct experience with Medicaid, either through their own enrollment or enrollment of family members. We wanted to build consumer input into our decision-making about which research topics to address, which questions to ask, and how to conduct the research, and to shape our understanding of which policy solutions would be workable to achieve better experiences for enrollees and better outcomes, particularly among historically marginalized groups, such as disabled people. I and other researchers on the urban team are deeply grateful to our CAB members for sharing their time and insights on our research, knowing full well the many demands they face at home and with the important work they're doing in their communities. Their commitment to improving our research and our research products and its impact, as well as their commitment to improving the health and well-being of people in their communities, is inspiring, and our meetings are a high point on my calendar. At the start, we look to our CAB to react to our research plans, our research findings, the policy implications we had identified, and the dissemination approaches we were planning, as well as to bring an equity framing to our research. And without question, the CAB's guidance and input have enriched and improved our research. And over time, as the CAB and the research team have gotten to know and trust one another, our CAB's role has expanded on the project. The research team and the CAB have collaborated on responses to proposed federal regulations, and has included suggesting improvements to our plans, to proposing research areas for us to consider, and participating on research teams and co-authoring reports, as with the research you'll be hearing about today. Next slide. I would like to acknowledge the Urban Institute's Disability Equity Policy Initiative and its Community Engagement Resource Center, both assets on which our project has drawn. The Urban's Disability Equity Policy Initiative team, which helped organize this event, is working to build a body of evidence that will help improve the lives of disabled people. Next slide. Urban's Community Engagement Resource Center has put together a set of tools and resources that are available to the field, not just to urban researchers, but to the whole field, that support the inclusion of community engaged methods in policy research. Next slide. You can see here members of full membership of our community advisory board, all of whom have played a vital role in the work that we've undertaken over these last 4.5, almost 5 years. You'll be hearing from several today. And with that, I'm going to turn to my great colleague, Miriam Hernandez. And the next slide, I think, would be appropriate to come up now, who leads the urban team that supports the Community Advisory Board. And here is the whole team. But with that, I'm going to turn to Miriam to pick up the ball here. Thank you.
Thank you so much, Jenny. I am a Latina woman with brown hair, wearing blue glasses, and black and blue top. So now I am going to talk about the role of the CAV in the project. Over the 4+ years of the life of the project, the role of the CAV members has changed from reacting to and reviewing studies to becoming research partners. And this has changed the way that we have been doing our work, and they have become research partners in informing study topics and designs. The urban team that supports the CAV meets with the CAV every month and facilitates joint calls of CAV members and urban researchers on a monthly basis before the joint calls. And the researchers send information and studies to be discussed to CAV reviewers, and schedule time to receive reviewers' feedback in advance of the meeting. Then at the joint meeting, researchers present on their project, and CAV reviewers share their feedback. after which there is time for group discussion with other CAV members. There are many components to the growing CAV involvement in the research. And in the interest of time, I will talk about two things which have been critical: building trust between advisory board members and researchers and the urban CAV team, and creating opportunities for researchers to experience the benefits of collaborating directly with individuals with lived experience. First, trust. Trust building has been an ongoing process, starting with the CAB members, feeling confident that we will listen to them when they recommended changes, as they observe how their feedback was received and integrated in the research. This has also included getting input from CAB members individually and as a group on how meetings and processes can be improved and what topics they would like to discuss, as well as having both CAF members and researchers evaluate how things are going and making adjustments based on that input. At the request of the CAV, we have also held CAV-only meetings so the members can build community with one another and hear presentations on topics of their choosing from different urban experts or from CAV members themselves. For example, urban staff from communications and government affairs have presented on best practices for communicating research findings with policymakers and other key stakeholders, how to provide comments on regulations and provide formal input to federal, state, and local governments, and on legislative processes. And researchers have presented on homelessness and evictions and policies aimed at reducing and mitigating them. And this past December, a CAV member presented on the effects of long COVID. The presentation was well received by CAV members who learned about several issues that they have not considered before the presentation. Another change we made to continuously build trust is how we conduct study reviews. For the first 2 years, CAF members used to fill out a form to provide feedback on studies. In the third year, and ever since, researchers began to hold calls with CAF members to obtain their feedback, thus creating a tighter bond between them. The most important change that we have made, it is to not only integrate their feedback into research in real time, but as Jenny mentioned, we have included our CAV members on research teams and included them as authors of associated work products. Lastly, and also crucial to our partnership with the CAV, is that researchers have come to see people with lived experience as collaborators and expert partners who help improve their research. The questions they ask, the way the research is conducted, the analysis, and perhaps most importantly, the applicability and relevance of the research to effect change. You will hear several powerful examples in a minute from my colleagues today. And now I would like to introduce Dr. Kima Joy Taylor, who, though no longer part of the urban team working with the CAV, she was instrumental in helping create the trust we have built with the CAV members that I just mentioned. She will facilitate the conversation with researchers and CAV members. And here is Dr. Kima Joy.
Thank you, Miriam. First, I want to thank all of you for coming to the conversation today. And I have to say, as Miriam mentioned, I was part of the CAB early on, and so I'm really honored to be invited back and get to talk about this research and the trajectory that the CAB has gone through. I do want to put a plug in for a previous conversation we had, and so that people who look back at the Urban website and watch that webinar that was a little more about how we began the CAB to see till now, I think you'll understand the evolution kind of even better. So without further ado, though, I would like to introduce one of the researchers, which was mentioned before, Dulce Gonzalez, who is a senior research associate at the Urban Institute. And we'd like to start with Dulce. Could you tell us a little bit about the research you conducted, some of the key questions and methods, as well as how the CAB overall and particular CAB members helped to shape the research and were integral to that work?
Sure. Thank you, Kima. And for the audience, I am a Latina with dark hair and glasses, and today I'm wearing a light blue sweater. So to answer Kima's question, in 2022, the Urban Institute began conducting a series of research studies on barriers to healthcare access among people with disabilities with support from the Robert Wood Johnson Foundation. And this work was motivated by discussions with members of our community advisory board. And going back to 2020, meetings between urban researchers and CAB members were focused on how the COVID-19 pandemic was affecting healthcare, with an emphasis on healthcare, health equity, and disproportionate impacts on marginalized communities. And during these conversations, one key issue that came up was a supply chain disruption that was restricting access to critical medical equipment and supplies, especially for people with disabilities who needed them for use at home. And the pandemic also worsened the shortage of direct care workers who provide vital home health and personal care services to people with disabilities. But despite the serious consequences of these access problems, there was limited availability of timely national data, especially for adults under age 65. And so we saw an opportunity to fill in some of these knowledge gaps using two surveys that the Urban Institute has been fielding annually, and which we adapted to focus on the health and economic impacts of the pandemic. And we also expanded our focus on additional health equity topics, including experiences of discrimination and unfair treatment in healthcare and in other settings. And here we list the research questions that we set out to answer with this work. First, we wanted to know, to what extent do working age adults with disabilities and members of their households have difficulty getting home and community-based services, which we call HCBS throughout, and other healthcare, and why? And what are the consequences of delayed and unmet needs for services, and what coping strategies do people use? And then finally, to what extent are disabled adults treated unfairly because of their disabilities and other personal characteristics when they visit healthcare settings, at work, or when applying for public benefits, as well as how does that affect their health and well-being? And when we discuss, just for background, when we discuss home and community-based services, we're referring to a range of health and social services that help people, disabled people with daily activities and enable them to live independently in their communities. And because our CAB discussions initially had focused on access to medical equipment and supplies, that became the point of entry for us when we started to explore these access barriers on the surveys. But CAB members were really instrumental in encouraging us to focus more broadly on issues like examining a wider array of services such as home health care and personal assistance services. They also encouraged us to look at intersections with other types of healthcare and to look at dynamics within households. So for example, disabled parents with disabled children. And so this expanded the scope of our research and pushed us to address more complex circumstances and how these different services are delivered, which ultimately led to a more comprehensive and nuanced analysis. And for this work, we took a mixed methods approach that included quantitative and qualitative methods. The quantitative component focused on analyzing the two surveys that I mentioned that Urban fielded in 2022. And those were the Health Reform Monitoring Survey and the Wellbeing and Basic Needs Survey, which are both internet-based surveys of adults ages 18 to 64, and that are designed to provide rapid turnaround data on key health topics. And each survey asked respondents whether they or someone in their household delayed or did not get medical equipment or supplies, home health care, personal assistance, and skilled therapies in the past 12 months. We also conducted qualitative follow-up interviews with 25 disabled adults who had participated in the second survey, and who reported having delayed or unmet needs for care. And our interview sample was diverse in terms of health insurance coverage, types of services people had trouble getting, types of disabilities, race and ethnicity, and presence of other disabled household members. We also used these surveys to examine whether adults had been treated or judged unfairly at a doctor's office or hospital, at their jobs, or when applying for public benefits in the past year because of their disability, their race, or any other or select other characteristics. And so this work did involve a deeper form of engagement and collaboration than the research team had been used to with the CAB, in which CAB members were involved at every stage of the research process. So in addition to helping us define our research questions, Crystal, Charisse, and other CAB members have provided feedback on how to ask about unmet needs for medical equipment, supplies, and services in the survey questionnaires. They also helped guide our interview recruitment criteria and our approach to that. Crystal helped us draft the interview guide and refine it after listening in, because she did participate in some of the interviews as well with respondents. And Crystal and Charisse both provided feedback on the drafts of the briefs, and helped us develop a strategy to make sure that the findings were shared with the right audiences. And so here I just wanted to present a few of the results, key highlights from the research that we did with Crystal and Charisse. So here on this chart, we show findings from our June 2022 Health Reform Monitoring Survey, where we found that about 15% of non-elderly adults with disabilities reported that they or a household member delayed or did not get medical equipment or supplies that they needed in the past 12 months. About 12% had trouble getting physical or occupational therapy, and about 4 to 5% had problems getting home health care and personal assistance. And disabled adults were more likely to report difficulty getting these services, both for themselves and for other members in their households. And on this slide and the next few slides, we just wanted to highlight a few key themes from our in-depth interviews. People told us, for example, about our problems getting a wide range of services, and usually people had trouble getting more than one type of service. Family caregiving was more common than receiving paid help among our interviewees, and reasons for this included that the interview participants did not qualify to receive paid personal assistance, shortages of direct care workers, and restrictions on spouses or other relatives to be compensated for caregiving roles. And the paid personal assistance that interviewees did receive was often unstable or inadequate. And several respondents also faced transportation barriers that made it difficult to get to medical appointments and pharmacies, which compounded problems getting needed care. So this included difficulties with Medicaid covered non-emergency medical transportation, which many people talked about. So several reported problems with scheduling rides, as did this person who we're quoting here, who said, I scheduled several different rides and nobody ever showed up. They couldn't get anybody scheduled to come out here to get me. I tried half a dozen times, and finally I had to drop that option because I knew nobody was going to come get me. And then consistent with survey results, insurance barriers were the most common reason that people reported for delayed or unmet needs. We only spoke to a couple of people who were uninsured, but they did face some of the most severe challenges affording out-of-pocket costs for care. And most of the people we spoke to were insured, and they told us that the services were not covered or that they were subject to coverage limits. And they mentioned having claims or prior authorization denied, as did this person who said, my insurance company sent denial after denial after denial. The medical equipment store said my insurance company denied it due to not being considered a medical service that's needed for me, even though all my medical records are saying that I need it. And so narrow provider networks and transitions in insurance coverage that led to changes in those networks were also a challenge for people, particularly for those who needed specialist care and people who did not have reliable transportation or who lived in rural areas. And interview participants also discussed problems applying for federal disability benefits such as SSI and SSDI, as well as Medicaid long-term services and supports. And some indicated that the disability determination process was complicated, prolonged, and costly, with applications only approved after multiple attempts. In terms of consequences, interview participants told us about harmful health impacts of going without services, including injuries, worse physical symptoms, chronic pain, poor mental health, and ER visits that could have been prevented. It also affected their ability to perform self-care tasks, clean their own homes, work, and participate in social activities. And the inability to work and out-of-pocket costs often strained household finances, leading to higher credit card debt and difficulty paying for food and other basic needs. And so the quote on this slide illustrates these difficult trade-offs. So this person saying, I had to pay $380. And of course, that means I have to take money from somewhere else because I'm disabled. I don't have an income. My SSI is $103 a month. So that means I have to cut back on food. And then finally here, some people told us how the shortage of direct care workers caused problems getting consistent home care and led to increased demands on family caregivers, job loss, financial strain, and high levels of stress and feelings of isolation. And on this slide, we show findings from the Wellbeing and Basic Needs Survey, where we asked people about whether they had been treated or judged unfairly because of their disability and other characteristics like race and ethnicity, among others, when going to healthcare settings, at work, or when applying for public benefits. And we found that disabled people reported unfair treatment in healthcare, at work, and when applying for public benefits at much higher rates than people without disabilities, with 4 in 10 adults with disabilities reporting this. And this finding was consistent across the 3 settings we asked about. So, for example, in nearly a third of disabled adults reported unfair treatment in healthcare settings specifically, compared to only 10% of people without disabilities. And so for anybody interested, research briefs that highlight the key findings and policy implications from our work are available on the Urban Institute website. And in addition to Crystal and myself, just wanted to give a shout out to other co-authors for these briefs that included Michael Cartman, Jenny Haley, Jenny Kenny, and Sadie Morris. And we've also continued to use our Wellbeing and Basic Needs Survey to conduct disability research, including some recent work on long COVID, the measurement of disability status in surveys, and disparities in material hardship. And we continue to benefit from CAB engagement in guiding this work. So thank you, and I'll turn it back to Kima.
Thank you so much, Dulce. And apologies at the beginning, I did not say who I was. So again, Kima Taylor, Black woman, kind of big kinky hair with streaks of gray and a blue top and glasses. But thank you so much for your research, Dulce. And I just want to ask you a couple of questions about the CAB involvement before we have the CAB speak as well. How would you say the CAB impacted your research in terms of thinking about health equity and equitable outcomes in particular across intersectional identities, race, ethnicity, sexual orientation, gender identity, socioeconomic status, and other possible intersections?
Yeah, so I feel like our conversations with the CAB always feel intersectional to some degree. When we've sought feedback from and collaboration from CAB members, we've talked about things like how being Black and being a woman, or how being overweight could be a source of bias or could be compounding bias when people go to the doctor. And we've also heard a lot from the CAB about how people with disabilities get treated unfairly when they go to the doctor, or they have inequitable access to healthcare, just to the facilities or to the equipment within healthcare facilities, because these are not accessible to people with disabilities. And so much more. And like I said, it always feels intersectional. It always feels very, very engaging and a lot of good information to learn. But through all those conversations, we've been able to refine our work in several ways. For example, we focused an entire brief on the experiences of unfair treatment in healthcare and other settings among people with disabilities. And we've collaborated with Crystal, Charisse, and other CAB members to get input on our questions and our designing our questionnaires. And we've also been doing a little bit more intersectional analyses when we look, for example, at experiences of unfair treatment in healthcare by both gender and race.
Wonderful, thank you. And then my last question for you is, over the course of these 4 years, because you've been engaged since the beginning and really actually all in, I will say, which was great to see from the beginning. So over the course of these 4 years, can you say something about the evolution of the CAB, about your sustained involvement in the CAB, and whether how you see community engagement in a new way as a result of working within the structure?
Yeah, and before I answer that, I guess I want to reiterate that I'm super grateful. I and the rest of the research team are super grateful to Crystal, Charisse, and everybody else on the CAB who has provided us with input and their valuable insights and contributions over the past several years. It really has been valuable to hear how my research resonates or not, because it doesn't always resonate, and it's good to know that from the CAB. And just it's been helpful to hear that from people's lived experience and hearing how their perspectives and on that, and all of that in turn shapes the direction and the context of the research. And working with the CAB has also provided a lot of just learning opportunities for me personally, which I'm really grateful for. And it's ultimately helped improve the final research products. I feel like I've been a little bit more mindful about the language that I use when describing context. I try to use more language around structural barriers and just acknowledging all of the different factors that the CAB has taught me. And it's also, the other thing I'll say is that even though the CAB has contributed to a very specific portion of my work, it's also had spillover effects to all of the work I do. So it's not just like this RWJ funded work, but it's also every aspect I try to keep in mind. And then just finally, I think there is something very powerful about bringing together researchers and community members who have so many different backgrounds and collectively talking about untangling and thinking through the potential solutions for health inequities. And over the years, I've seen that the CAB members and researchers working with the CAB have bonded with each other. And it feels like the CAB has become a safe space where people can talk freely about their experiences. And we can tackle difficult topics in partnership and without judgment. It doesn't feel like we can have difficult conversations and not feel judged and not feel like it's an attack. And that's a really powerful setting to be in. And it's not easy to get that kind of rapport. And so it feels like once you have that, it's really important to keep it going, and it's going to be instrumental to helping us uncover new research directions that maybe we hadn't seen before or thought about before.
Awesome, thank you. And one thing you said, but didn't explicitly say, that I think is really important, right? We put together this CAB because people had lived or living experience with Medicaid, but that is just one aspect of any individual's lives. And the fact that folks can come and bring their whole selves to the table and have these conversations is really important, and really important not to pigeonhole or give people one snapshot view of who they are. And so I really do commend the work that you've done and the engagement that we've had with the CAB. So thank you. And then I'm going to turn it over, and we're going to switch viewpoints for all of you and move from the research and researcher perspective to talk with two of the CAB members who have been actually there since the inception. And I'm really honored to know them. Like, these are amazing people, as is Dulce. So I want to open it up for Crystal Evans, who's a member of our Urban Institute Health Equity Community Advisory Board, and also to Charisse Rhodes. And what we're going to do is I'm going to ask questions. If you guys want to come on camera, I'm going to ask questions and I'm going to alternate back and forth. So again, thank you guys for being on. This is a huge time commitment, and so thanks again. But I wanted to talk a little bit about the process and the interactions with the CAB. Yes, talking about the disability papers for people with disabilities and that content, but also talk about the process to get there. So I'm going to start with Crystal and just ask, how and why did CAB members bring up the idea of inequitable outcomes within the CAB? And did you feel comfortable bringing up these issues? And if so, why? Or if not, why not?
Yes. I've been a member of the CAB since it was started back in 2020. And I believe it was March 2022. So by that point, we had developed relationships. We've been working together for a period of time. And even though at that point our relationship was all strictly online meetings, it's like you kind of grow a sense of trust as you're working with others. And March 2022, I had brought issues up around the supply chain issues stemming from COVID, and I am ventilator dependent. And so, of course, as soon as the pandemic hit, I fully expected impact to the home vent users, which is exactly what ended up playing out. Where hospitals were bidding higher for the same supplies we needed in our home, and the vent supply companies serving the community were unable to get a lot of the equipment being produced because COVID was being prioritized over chronic vent users. And there were a lot of other issues going on around who gets what treatment in hospitals when there were ventilator shortages themselves and other things early on. So I had vaguely brought these up into meetings, but then March 2022, the Washington Post did a front page story with me on these supply chain issues, me and two others I knew, and then also interviewed some, big hospitals nationally talking about the deficits, the supply issues that they were facing and trying to provide patient care and the number of back ordered supplies they were dealing with. And so I felt comfortable at that point sharing the article with the advisory board because these were issues I had brought up in meetings. So I don't want to be like, hi, here's a news story, but it pertained. And it right away, people had jumped on it and were like, this is something we should be using to collect actual data on with our coming surveys. And they approached me and asked if I would be willing to be a part of doing more in-depth research on the issues that I had been bringing up all along, and then that the Washington Post covered so thoroughly. So of course I agreed to that. And I mean, because I had developed a relationship with these people, I was very comfortable in doing so. It was like I knew where they were coming from. I had seen their other research, and I knew that working with them, we were going to be able to get a good assessment nationally of how things were hitting people state to state. I mean, there were other issues like suddenly ending up struggling to get home care workers in fields that weren't a problem before, but just people kind of had to reshift their lives. It's like kids might have been going to online schools still nationally. So then the people that were working in these home care jobs are now at home with their kids, and it's like there was this huge domino effect of the impact, not just with supplies, but in accessing basic home care. And yeah, so we ended up moving forward with surveys and then using the data from the surveys for actual research.
Thank you. Charisse, I'm going to ask the same question to you. How and why did CAB members bring up the idea of inequitable outcomes? And did you feel comfortable bringing up these issues? If so, why was that? If not, why weren't you?
Okay, so thanks for the question. I was not one of the CAB members that were there from the beginning. I was invited to fill out the application from a CAB member who had already been involved since the beginning. And I'm gonna be real, when he was first kind of explaining it to me, I didn't want to have anything to do with it. And it's because of the fact that when I think about data and typically like how it's used, it is about someone who has no true interest on uplifting and changing community, but it's like to talk about the deficits, like how we're behind. And I felt like I've done a lot of that. With me being, disabled, I felt like I wanted to harness or focus my energy on making impactful changes, right? Like doing some legacy work so that it may not be great for me, but it'll be better for the people that come behind me. So when he gave me, and this person's pretty persistent. So like, they kept, having conversations with me on how this would be different, how I could come in as my whole self, because that's another thing I feel like, a lot of times it's not safe for me to say that I'm disabled, right? Because then there's other things that are placed up. And also, with being an African American woman, I already feel like I have to work 10 times harder than others, right? Like, but it was from the trust of that person and explaining like all the things that you guys were able to do, or like the things that you guys foresee to do. It made me take that chance, right? And step into the waters. And I'm excited that like I still don't have a love language with data, but I do appreciate now that I can see that we can be the writers of data and actually make the things that make sense in order to advance us instead of always talking about the things that we're not able to do, right? Um, so yeah, that's kind of how it worked for me. But I also really appreciate that, like, in order for you to understand some of these systems and how it's failing us, you do need to have conversations with those who are utilizing those systems to be able to figure out the cracks and the flaws within it.
Thank you. Yeah, and I think what you just said, and also what Crystal said around the COVID, I mean, all those pieces for me feel so much more important now as we're looking towards looming cuts and other things, really understanding and listening from the people impacted to say what is going to be most effective, what is it that we're saving, and how do we save it to make sure that happens. Um, and I guess so, Sharice, I'm going to start with you with the next question. And you kind of answered where we were going to go. So I'm going to move to something else, take liberty to something else. Sorry. But did you feel anything was missing? Like when you're making recommendations or on this paper or in other spaces, did you feel something was missing? Did you feel that there are recommendations that what recommendations did you make to make things more complete in these conversations? And then Crystal will ask you the same question.
Yeah, there were times that like we would be able to get the feed or give the feedback to the researchers about some of the things that we felt like were missing or I felt like was missing. But I think that the great thing is, and I don't know if it was set up this way from the beginning or if it could have been dealt this way through funding, that a lot of times some of those things that people had talked about in one snippet has come back for us to still continue to build off of it. So I feel like, and again, I don't know if that was by design. To me, I feel like it's brilliant because a lot of the times I also feel like we give our input and we don't know where it goes, right? Like, and even if we say, like, well, have you thought about this or have you thought about that? A lot of times I feel like things are shelved and we don't know why, right? Like, they don't come back to you. So, no, I think that also the things that I love is like when we're able to have these conversations with researchers, like I am one, you guys adapt to what our needs are, right? Like, so like originally it was forms that we kind of read and we went through, but I learned that I'm the type of person that likes to have conversations back and forth. Well, how did you guys come up with this? How did you guys come up with that? And with being able to like pivot to what our needs are, I think also is a reason on why this is successful. But I do love how it circles back.
Thanks. I will say we did promise from the beginning, it's always my intent that if someone gives a recommendation and you can't follow it, you go back and say why. But I can't pretend that the other piece, like that we're all knowing, and I think that's an important piece of the cab. Like we learn from you, and often when we go back, it's because y'all are like, bring it on back. We need to go back to that topic. And so I think the pieces, and we've been really lucky with all of the folks, the research, etc., to researchers and others to say we're learning at the same time. Right. I like you can't do this and have a set thing in place and pretend it's always going to be that way. And the willingness and trust of the cab members to say, we need to fix this is incredibly huge. So we're honored by that. Crystal, did you feel anything was missing as you were having the conversation? I'm sorry, talk fast. I'm trying to slow down. When you were having the conversation, either on this research or other spaces, and were there recommendations that you made and why? And did you feel heard?
Yes, I worked on some of the, or reviewed some of the survey questions before they were even sent out to the public. And in Massachusetts, I work on the One Care model here. So we do a lot of survey data with the consumers that are aged 21 to 64 and dual eligible. So I'm very familiar with the types of survey questions being asked of people with disabilities, but often it's generic checkboxes of what category of disability do you fall under? You know, is it a physical disability? Is it impairing your mobility, your vision, your hearing, intellectual disability, mental health, you know, just the very standard boxes. But the issues I was raising around supply chain issues and home care needs, some of them were affecting very specific populations, and generic checkboxes of physical disability was not going to be able to capture the data appropriately to be able to zero in and kind of look for some case studies. For example, there was a global silicone shortage that was impacting tracheostomy tube production, as well as feeding tube production, in addition to other medical equipment that needed silicone chips. So, and I knew that these were some of the bigger supply chain issues because of these global shortages. And I had people in Massachusetts reaching out going, look, this mom has no spare feeding tube for a kid. Do you know where we can find this stuff? So it's like, in order to really tailor the study to look at some of the disparities within various groups of people with disabilities, but it was like we broke down the questions further, because then we can capture the needs of those that are tube fed, those that are dependent on ventilators, those that are dependent on CPAP, BiPAP, because also around the same time, there was a big recall on a certain manufacturer's BiPAP equipment. The filters were carcinogenic and breaking down. So it was like, I knew there were big disparities with CPAP, BiPAP equipment at this point going on. And like, I had heard stories of people getting their equipment replaced, but then they forgot to send them a power cord for the equipment to even work, you know? And it's like all these little details. I'm like, we need to make sure we're grasping. Are we talking vent users who are dealing with COVID shortages versus people who are dealing with equipment recalls, not able to get what they need and not able to afford alternatives out of pocket, you know, when they're Medicaid recipients? So I was able to really help break down the questions further so that we could really look at some of these niche areas of different types of different categories of people with disabilities, physical disabilities in particular, and how this was impacting their access to supplies, equipment, or home care services that are needed, because not every disabled person even needs in-home care. Disabilities are very diverse. And yeah, so it was like I was able to really kind of guide the researchers around the surveys before anything even went public. And I feel like in the end, the data we were able to collect had a lot more value because it wasn't just generic checkboxes. Yes, I have a physical disability. It was more specific into looking at niche areas that related back to causes of some of these problems.
Nice. And as both of you alluded to when you're talking about this, it's doing things so that there can be positive outcomes, not the what's wrong tour, right? It's the really listen to us so the outcomes can really have positive effect. And researchers can utilize it to make recommendations that will lead to those positive effects. So I'm going to ask you guys the last question that I also asked to Dulce, and we'll start with Crystal. Over the course of these 4 years, can you say something about the evolution of the CAB, your sustained involvement in the CAB, and whether how you see community engagement in a new way as a result, and or research in a new way as a result of working within the structure? And why is it important to continue this CAB researcher relationship?
Yeah, I've been on since the beginning, and it's an internet working relationship. It can be great. We can get to core roots of issues. And again, a lot of us are doing work back home in our communities. We've got people all over the country. And it's also interesting listening to people from other states talk about what's going on in their area, what they're working on, especially as, you know, we're often in overlapping fields outside of our CAB. But I mean, for me, one of the big changing points was when they brought all of us together with the researchers in DC. I think it was March of 2023. There was a big meeting. We were invited down. So we were actually in the middle of this research we were publishing anyway. And I feel like it could really change the dynamic of being able to be with people in person. We're all in the same hotel. It was great. So it's one thing to have a 2-hour structured meeting on a monthly basis. It's another to just hang out with people and get to know them beyond our icebreaker questions and the topics of conversation on surveys. And it's like, once you really start talking in depth of what you're doing in the community, it's like you can learn so much more from each other. It's like, I loved that. And it being able to do that, I feel like it really strengthened our relationships with each other, to know each other beyond just the topic on an agenda. So I feel like that was huge. And it's like, I'm often working on stuff locally, and it's like, I'll think of another CAB member, be like, I should probably talk to them and find out. I know they vaguely said something. I want to know more, start poking around online to find out exactly what they were referring to in their community, and, you know, and bringing stuff back locally on other projects I'm working on.
Thanks. And Sharice, I'm going to ask the same question to you. Over the course of your time, which I guess is actually like 3 years, can you say something about the evolution of the CAB, your sustained involvement, whether how you see community engagement or research in a different way, which you alluded to a little bit, but also why is it important to continue and sustain this partnership?
Okay, so for me, I never have had the liberty to have a lot of spaces where I can come to and bring my whole self, right? It's like I only get opportunity to talk about little pieces. I love that here I can bring all of the knowledge that I have from what would help myself, my family, and also the community in which I serve, right? Um, I like to tell people all the time, it's like, yeah, I don't have a typical degree, right? But I have a living doctorate that grows every day, right? Because I definitely know my truth and I know my community's fight and stories. Um, why do we continue to need to have this? Is because of the fact of things are changing and um I'm trying to find a way to say it without getting emotional or anything. Um, you know, with some of the changing things, like I have direct targets on my back. One for being a black, one for being a woman, one for being disabled, right? Um, so like as much as like I said earlier, I really want to start leading and doing legacy work. But because of the fact that someone else doesn't see the value in me, um, it makes it hard for me to even understand what that legacy is going to be. But that doesn't mean that I'm giving up, right? Like that means that I'm going to press harder and I'm going to try to find other people to stand with me and you know, that we can continue this fight. I know that it's going to be difficult. I know it's going to be extremely challenging, but I know we need more people and more funding to be able to continue to fight, right? So that we can push back and show that a Sharice and a Christelle does have value and we do have worth. Um, I think the other thing is a lot of times when people talk about disabled people, there are a lot of more protections, or I feel like things that are there's more access, right? Like, so for my kids up to 18, they have a whole lot more access than I do from 18 to 65. I don't know if people feel like I go on sabbatical and hopefully you make it till 65, but like, you know, it's not the same. Um, yeah, I didn't speak earlier about do I have val or do I feel like when I bring up issues, am I being heard? I am definitely heard, right? And that's why even though life is lifing outside of those spaces, I make sure that I show up for those meetings. I make sure when I'm called to give my contribute to a research that I do that. Um, I also love that you guys are very robust with the different things that we talk about, right? And that I also feel like that doctorate is still growing because of the fact, like Christelle said, I'm also able to hear about things aren't just an issue in Washington State alone, right? That these are issues all the way across the world. I hope I answered all your questions because I felt like it was quite a few questions within that
It was,
question.
wasn't it? It was. And both of you did an amazing job. And I will say, one thing you said, Sharice, the nice thing I think about the cab was I got to bring my whole self to the table as well. And I think that's incredibly rare. And as you said, it's going to be so important moving forward. And it is unjust and unfair that people have to justify their existence in this day and age. But we will push forward and keep moving and find our people to partner to get to those equitable outcomes that we talk about. And I do want to state, as they'll be back on camera, but both Crystal and Sharice, I know their work outside of this cab, and so it is those connections. These are some like bad A women that are going out and changing the world, and those connections you can see happening. And so again, just knowing now I'm on the other side, more of an advocate, to know that there's people in all of the different states means we are going to make those changes, despite a bit of an uphill battle, to put it lightly. But want to thank you all again for joining. And like I said, we're going to bring you back on for Q&A, but I want to push over to the discussants. And I'd like to now introduce the two discussants we have on board. The first, as Jenny mentioned, was Mia Ives Rubley, who's the Senior Director of Disability Justice Initiative for the Center of American Progress. And the second discussant is going to be Noelle Sanders, who is also a member of the Urban Institute Health Equity Community Advisory Board, but again, is also an advocate and amazing person outside of the CAB. So Mia, I'm going to turn it over to you. And thanks again for agreeing to do this.
Yeah, thank you so much for having me. I'm so glad to be here. I hope everybody is enjoying the warmer weather. My name is Mia Ives Rubley. I am the Senior Director at for the Disability Justice Initiative at the Center for American Progress. I am an Asian American woman who has short black hair and has a top on that is repping my old alma mater, Illinois. And today I'm gonna talk a little bit really quickly about sort of how CAP does its own research, because while we are a sibling organization to the Urban Institute, we our priorities are a little bit different, and we do certain things a little differently. And so I wanted to just describe a little bit about how we go about our work. Our work is very much a mix of qualitative and quantitative analysis. We develop policy from the ground up by getting feedback from the community, somewhat similar to the way that the Urban Institute does, except for our community of advisors is not a single group, but we do a lot of conversations with a lot of different community members throughout the United States. So our feedback loop is a bit broader. We we try to have basically a step-by-step process of how we go about our work. And that starts with hearing from the community. Sometimes it's online, sometimes it is in big group discussions, but we try and hear from the community on what its priorities are. And then we basically develop a theory of a policy. So we try to sort of somewhat reflect off of the comments that we get from folks and decide sort of how that is impacting specific policies. And then we do a lot of background research, and that can include looking at other research papers, including from the Urban Institute, and from different universities, different academia settings. And then we also do interviews. We'll do intensive interviews with individuals who are impacted, whether it's the disabled person themselves, if it's the service provider. We just try and gather as much information as we can. And then we try and synthesize all of that data. We code it and try and build a bit of a narrative of sort of why we think a specific approach would be appropriate for a policy. And then once we sort of develop this, what we term work product, which is usually a column or report, what we try to do is actually synthesize it even broader so that we can communicate with the community and others about sort of what our stance is on different policies. And then we kind of get that information out into the community, to policymakers, to lawmakers, et cetera, to sort of communicate our messaging. Once we do that, we try to get a lot of feedback from the community on what they think about the policy, and how much buy-in they have into it, and whether that leads them to other issues within the community. And so those are basically our process for how we get to the work that we do. So we balance our work between policy research and advocacy. And we try and advocate for specific policies through community engagement, through engagement with folks on the Hill and with the White House. Um, the next thing I wanted to talk a little bit about is sort of gaps for future research. And I think this is something that we continually try to find where there are gaps and holes in research and try to figure out if it is valuable for us to dig into those gaps, to help uh, particularly some of the most marginalized in the communities. And so a lot of times we are looking at research at the intersection of disability and other communities, to try and find sort of the most salient issues. And some of those examples include, we have been doing some work on disability and immigration and migration. We put out a report called Crossing the Border, how disability civil rights protections can include disability asylum seekers. And so we did this report basically by, again, interviewing those most impacted by it. So we spoke with migrants, we spoke with providers to hear from them about what issues that they were seeing on the ground, and the things that they wanted to see either changed or developed. And then spoke with a lot of different lawyers, and I just put the link to the article in the chat, and tried to synthesize a lot of that information to develop sort of how certain basic civil rights from the disability community translated into migration, immigration, refugee status, et cetera, and trying to talk about that intersect. We have also worked along the lines of LGBTQ status and disability, and our paper was called "The United States Must Advance Economic Security for Disability LGBTQI plus workers." And one of the great things about CAP was that we have multiple different teams that are focused on specific issue areas. And we were able to work with the LGBTQ team to review their data that they got from a survey that they had done. To evaluate the impacts of or the intersection of impacts of ableism and anti-LGBTQ policies. And so one of the interesting things that we found was, of course, that there is a lot of intersection between the disability community and LGBTQ community. And with that intersection, we found that individuals experienced a mix of barriers that they faced while dealing with things like employment, obtaining healthcare, etc. And we found that LGBTQ disabled people were more likely to face significant economic concerns, including lack of housing, lack of employment, and lack of health care. Another example of an area that we have found sort of somewhat lacking, but we've actually seen a bit of growth in this area, which is disability and reproductive rights. As we saw the Roe fall a couple of years ago, we realized the importance of better communication between the disability community and repro rights communities. And due to those concerns, what we wanted to figure out was, how does disability get impacted by some of these regressive policies that impact the general community? And so we have been working in coalitions to discuss the wide variety of issues, including lack of access to specific medications, lack of access to certain treatments that disabled people may utilize either for reproductive issues or for the various disabilities that they have as well. And so we have done multiple pieces on that, but our most recent piece was, it's past time to address reproductive equity for disabled people. And we're actually going to be hosting a summit coming up in May to talk more about these issues and how they intersect. So I think it's really important to always be thinking about sort of what is missing in sort of the grand work that is being done, not only at the Center for American Progress, but also at the Urban Institute and at other think tanks and academic institutions, so that we aren't missing key elements that are important, particularly for some of the most marginalized in the community. So and the next thing I really wanted to talk about was how researchers can communicate with and be informed by and incorporate community members. And part of this discussion I want to talk about are two different issues that I know the disability community is interacting with. And one is the discussion on Medicaid and the proposal to remove $880 billion from that program, which would basically decimate the program overall. And one of the things that I think we have found extremely important in terms of our communication of policy to community members and receiving information from them is really incorporating things like what the Urban Institute has, which is the CAB, so community and advisory boards. Also being very engaged at events for the disability community and being engaged online as well. One of the things that we try to do is actually connect with some of the folks who have broader engagement in the community, particularly what we term as influencers, to try to summarize certain bits of information to provide it to them so that they can better inform the community without a lot of the misinformation that can come about through their own research. And so around Medicaid, one of the things that we've been doing is trying to put out specific data points to the community and talk about specifically how different ways that that Congress is looking at to cut Medicaid, including things like um, work requirements and specific caps on spending. All of these things are complicated policy discussions, and what we try to do is sort of summarize those discussions into digestible nuggets so that individuals who have broader communication with the community can talk about and utilize those talking points to help them with the work that they are doing in the community. Another thing that we should be starting to think about in particular is cultural competency and what disability means across different communities. A lot of times what we do, particularly at think tanks, is communicate in a way that is very much geared towards policymakers, policy wonks, educators, and that makes it very difficult for specific communities, particularly marginalized communities, to be able to understand what we're talking about. And so the things that we need to do better is uh, get really involved in community and cultural competency lessons. And that can be done formally or it can be done informally by actually going into communities and really investing time and resources into those communities so that you can better understand how to communicate with those communities and receive feedback from those communities. And so that's something that I have been trying to do, particularly in the AAPI community, is develop a better language with community members to talk about importance of specific policies, et cetera, and then also develop specific events for those communities or attend specific events within those communities to engage. Lastly, I would just say connecting with disability organizations, particularly if you're not a specific organization led by disabled people. That's also another important area that you can communicate and actually get a lot of storytellers and community members to engage with. So I hope that's helpful for folks to understand how to sort of think outside of the box of the per usual work that we do at specific think tanks. And I wanted to actually throw it over to Noelle.
Thank you, Mia. That was such a poignant presentation. I'm gonna pause here just in case Kima has anything to say before I jump into my segment.
Nope, it's all you, Noelle.
Awesome. Okay, well, my name is Noelle Sanders. Image description, I am a first-generation Black woman in her early 30s, wearing a black shirt and a KN95 mask. And I'm also going to try my hardest to remember to slow down because we have ASL interpretation. So please, Anna, feel free to interrupt me at any time if I'm going a little too fast. But yes, I'm a CAB member and I'm senior community organizer at the Boston Center for Independent Living. We are a predominantly led by people with disabilities organization. And I myself live with disabilities, but in my comments, I just really wanted to amplify my experience, but also some larger trends that have been expressed by community members that I work with quite regularly. And the question that I was asked is, what are some of the gaps that future research should address when it comes to interacting with people who have disabilities in a research context? And there are so many. I tried to boil them down to three. But the biggest one I'd have to say is a lack of follow-up with study populations in general, but particularly when that population is perceived to be largely people with disabilities. And this is a commonly shared grievance within the disability community from members who have voluntarily been a part of clinical trials or other processes for new medications, even just experimental treatment and sharing their experiences with inequity in the healthcare system. And I've seen it firsthand. People that I work with have consistently expressed feeling abandoned by researchers who have involved them. And they have repeatedly come to me and other organizers like me, hoping that we can be the one to facilitate this follow-up because they're usually ignored once whatever that survey or study was is considered concluded or over. And there isn't that long-term relationship being built between that community and the research team when typically the selling point for these studies is almost that promise, right? Of we want to engage with this community, we want to engage with you as a demographic, and this is going to be work that is progressive that we build on. So it's very inconsistent to reconcile that with the experience of once the case is closed, so to speak, the survey is closed, the study is closed, it's just over and it's hard to get in touch with even the researchers you worked with. So in many cases, their attempts to reach out, like I said, have been ignored. And it is somewhat understandable through a programmatic lens because the studies are truly over. But it is neglectful, again, from that community standpoint. It damages the trusting relationships that were initially built in order for community members to feel safe in participating. It's crucial that researchers prioritize following up with those populations that they're researching. And people need to also know long after everything is over what their contributions accomplished, or at least how they were used or integrated into other settings, in order to not feel used or manipulated, even if the study is over. The effect of feeling discarded translates into reluctance to interact with clinical and academic institutions in the future. It has sort of a cyclical building block effect that will affect other researchers long after whoever the first researchers to start this cycle of neglect will interact with. And this respect also of valuing feedback after things have concluded has been denied to people with disabilities separately and people of color. So the intersection of those two, people of color with disabilities especially, it's so important just to note that overlap of demographics and continue to fight that neglect. I'm just going to take a quick second to check my time. Okay, awesome. Halfway through. Another important point, a norm that should be solidified is fully accessible data publishing, meaning social accessibility, linguistic accessibility, and also just technologically accessible. Accessibility. Research institutions often publish data that's not translated into the languages of the communities that they've studied, and on top of that, often not accessible for people with disabilities who use interpretation tools like screen readers, braille conversion, and other adaptive technologies. And what this results in is these studies, published papers, reports, everything like that, they're already notoriously hard to interpret for people who don't have backgrounds in academia or medicine or science, but not even being able to fully engage with them or read them compounds all of that and makes it even harder. Data and findings need to be published in formats that are meant to be engaged with by the same people who are studied. And that shouldn't be an afterthought. That should be prioritized just as much as it is fitting it within clinical recommendations or what's the word I'm looking for? Requirements for publishing, depending on where it's being published and how the information is being shared. Same with also data collection transparency. People need to know how the findings they contributed to will be used. And this need is amplified by the fact that historically, findings have come at the expense of those people who were studied, and they weren't translated into better care or treatment for the people who are subjected to studies, which is often the selling point. When you're asking someone to participate in a study, it's often under the guise of, oh, this will help make medication that will improve your quality of life, or this will just in general help you in some way. But when participation historically has been largely compulsory and without compensation, we think of the Tuskegee trials, for example, the Tuskegee experiments. We think of situations like Henrietta Lacks not being given the opportunity to give consent for her cells being used. Just knowing this and the predominance of it happening in disabled communities of color has led to community skepticism and distrust. So going forward, even if the probability of that happening is slight, it's important for researchers to be open about how data can be misused, but also acknowledging this and letting people know that their active intention is to prevent this misuse will go a long way in establishing trust. Just another time check. How am I doing, Kima?
1 more minute.
Awesome. Okay. Struggle. Be direct. Just another bit of feedback. Be direct about your intentions for how that research will be used, and disclose all of the ways you envision this research will be used. And that kind of is also just flowing from what I just mentioned. Another example is the insurance industry's use of QALYs, or qualitative adjusted life years, to determine the cost and accessibility of medications. You would think that would help the people with disabilities who are involved in those metrics. But in reality, it was used to figure out what are the most essential medications that we can upcharge or charge more for. So in that respect, finding what improved people's quality of life, it did the opposite. It didn't actually improve it. It was used and weaponized against them. The patient, the consumer, ultimately suffers from this collection of field data. So again, people with disabilities' usual experience in this context is to participate and then see their feedback used to justify regulations that are harmful to their living independently. And that's kind of why you will hear a lot in disability spaces, especially in BIPOC-led disability spaces, a phrase that's often used, nothing about us without us, meaning this tenet of people who are being worked with, being in leadership and in control of how these processes happen, should be a guiding principle for health equity researchers. And I will pass it over to you, Kima.
Great. I'd ask everyone to come back on. And apologies, we're running late, but we do have time for a question. And it's a two-parter, but I'm going to start the second piece. And it asks how CAB members stay motivated, given how long research and real change can take. Thoughts? And anyone can answer. We're all calling you.
I mean, I guess I can answer. For me, I have to, right? Like I said before, I'm trying to leave legacy work. And I have to think about, even though things aren't perfect, I am living my ancestors' wildest dreams, right? So like, I know the civil rights movement, it didn't begin, right, like in one day. It took many of people continuing to apply pressure, right, to continue to keep making those ripples. So for me, if it's gonna be, where hopefully it's no time soon any grandchildren, but grandchildren are to say like, yeah, whole nother story. But like, um, if that is something, right, like that can be that legacy, right? Like that they had an amazing grandmother who they were able to stand upon her shoulders and things are a little better. Am I not gonna say that I don't get burned out? I do, but I think that, and again, I don't know how you guys all started the roux, right? But I feel like the sauce is amazing. I feel like, we are genuinely trying to move the same issue, whether that is a researcher or a CAB member, right? And I feel like there is genuine concern to really make sure that community is centered in that power, right? Like she said, nothing about us without us, but I also feel like those um that are the most in need have to be positioned in spaces where they're the closest to the power.
I agree. And I would also add too that I think, especially now in this political climate, our thoughts are mostly centered around the ground we're losing, right? We're losing ground. But I think it helps, especially in research and processes like even community organizing, where these things take that, like Cherise said, legacy, that time to build. We can think of lost ground, but we also need to think of the ground we've gained and focus on how if we were able to do that, just like also Cherise referenced, the civil rights movement, we have that to build on. So it's not just about like, oh, we're losing our rights or we're losing our access or everything that we've worked for. It's we've gotten to this point because we have gained, and we just need to work a little harder to push so that we can keep that momentum going. We need that forward momentum, and focusing on that will keep us hopefully from experiencing just in general burnout, I think, which is a big thing I'm also seeing in medical spaces, especially, but clinical too.
Yeah, our ancestors, right? Mia.
Yeah, along with what Noel had stated, I think, thinking about the ground that we are covering and are able to move forward, I think a lot of times we have difficulty remembering to celebrate those wins. And even the smallest things, because a lot of times we're like, oh, I have to wait until I get this far into the work to be able to say, yay, like we got there, when it can really be like, oh, I got 3 interviews for X thing, or I got my IRB submitted and it got approved. Like I think we think that we can't celebrate until the end, and that's not the case. I think that's a really important thing to understand in our work, and also understand that, like, yes, we need to wait until our papers are completed, but we can share certain pieces of information if it helps the movement. I think a lot of times we get so cagey about the work that we do, and fearful that people are going to take it, that it becomes almost its own barrier to the community that it could benefit from. And so, if it's going to take, with certain academic papers, it can take years for it to come out, and that's not helpful to the community, particularly if it's on something that is very salient and needed at the moment. Then sometimes it's
Yes.
important to release that information as soon as possible. That way, the community can start utilizing that information, and that gives you a win in a way. And that gives you something that you can count as something moving forward. So those are all really, really important things to understand, and to understand your a piece in the cog. We're all working together in this moment to try and continue to push forward and reduce the step backwards. And that's a beautiful thing.
Thank you. So my next question is for Dulce, and it's are the 2 quantitative data sources restricted to community dwelling populations, or are adults living in group homes or institutions included?
Yeah, so maybe I should have mentioned that in the presentation, but that's one of the bigger limitations of our data. Is that because of the sample that or the panel that we draw from, our sample excludes people who are in institutionalized settings. Unfortunately, that is one limitation that we do state in the briefs. I should have mentioned that in the presentation. And the other big limitation too is that like because the surveys are online, they could potentially exclude people with disabilities who might not have access to that sort of format for taking a survey. So that's another one of the bigger limitations, unfortunately. But yeah, we're always hoping to expand our research. So yeah, thanks.
Thank you. And then my last question, which we only have like 2 minutes till we move on to the next person, but it's related, as Mia and others alluded to, Medicaid is under threat. And thinking about the threat that is Medicaid, there's one thing that doesn't come up often, which is really around managed care. And as you were doing your work, Dulce, or as many of the CAB members are engaged in their existence, is there another layer of this research that needs to be cut to look at that managed care interface? Mia?
Now you asked other people. I'm sorry. This is actually something that
Yeah.
I've been very, very adamant about. And the fact that managed care or HCBS funding is actually much more than just the healthcare setting, and provides things like vocational training, vocational supports, and also just general sort of life supports, such as case management. And I don't think there is quite a bit of info or research on this part of services. And so oftentimes it goes ignored and people just think of care workers, they think of the specific money that they receive. And one of the things that I have been a little annoyed about is when they talk about the increase in LTSS or HCBS funding, that money might not go or might well go towards those services, but nobody is talking about it.
Thank you. And Crystal, you wanted to respond as well, and then that's the last response.
Yes, I had mentioned earlier, I do work on the Massachusetts One Care model, which is for dual eligibles age 21 to 64, and that is considered a managed care plan. We also have a lot of accountable care organizations in Massachusetts, which is similar. Managed care can work really well for certain types of disabilities, making sure people are getting their needs met. But one of the biggest areas I hear trouble for people with disabilities and managed care is those with rare diseases, because networks can be extremely narrow and you might not be able to see providers. You might not be able to cross state lines with providers when you're dealing with some of these Medicaid related programs. And if you've got an unusual rare condition, you might not have a provider in your area. Often when people don't understand your condition, it can become a barrier when there's managed care and the people managing you and at the center of everything. The patient should be technically at the center, but it doesn't always play out that way. So when the other person, primary care, whoever is the center of the care team, and they don't even understand your condition, it can just create so many more barriers to care. There's a lot more gatekeeping involved with managed care. And I hear those critiques a lot from others with rare disease, and I am also living with a rare disease.
Thank you. And just wanting to keep some of these topics, before I let you go, keep some of these topics at the forefront as we really look to see some of the changes in Medicaid, because it's going to be really important, as Mia was talking about, the things that aren't seen and aren't counted, to make sure those are included as we move forward, that really in ways that seek to achieve equitable outcomes. And I would say kind of the nice the way that researchers and the CAB work together is, again, really identifying not just policies to do, but policies that seek to have these equitable, positive outcomes. And by having that community voice in the community advisory boards, and there's many other ways to engage and necessary to engage with community, but community advisory boards is just one way. There's many different ways that you can ensure, as Dulce alluded to, that research, the development, implementation, dissemination, evaluation really can achieve the best outcomes possible, always looking to then improve as time goes on. But I want to thank all of the speakers, because we really value your input and your willingness to be on camera. For many folks, it's the afternoon, but for those in California and Washington, earlier in the day. So really appreciate your input. And lastly, just to round out the conversation, I am honored to turn it over to Catherine Hempstead, who's the Senior Program Officer at Robert Wood Johnson Foundation. As Jenny mentioned earlier in the conversation, none of this work and collaboration would have happened without RWJF's ongoing commitment to and belief in the importance of community input and voice in research, policy, practice, and all facets of both health and healthcare. So I really want to thank Kathy and turn it over to her.
Thank you. Thank you very much. I'm really glad to be here at the end of this really wonderful event. And we have supported the inclusion of a community advisory board as a really important part of our research that Urban is doing on Medicaid and health equity. And we place a lot of value on community engagement whenever we can get it. And I think it's especially important in the case of Medicaid. And I think everyone has heightened awareness right now of how important Medicaid is, and especially the long-term services and supports that we've been talking about today. But this partnership has had a really big effect on the project and improved the research by making it so much more relevant and so much more reflective of the lived experiences of participants. And I think that this research documenting the barriers that people with disabilities experience getting access to services is something that you really can't do without having that perspective that comes from people with lived experience and from a community advisory board. So we've been really happy to support this work. We're very proud of the accomplishments of the community advisory board, and we think that it is a great illustration of the value of getting that perspective of lived experience into health services research. So thank you very much.
Thank you. And Jenny.
I was going to say thank you to Dr. Kima Taylor, to Catherine Hempstead, and to our CAB members and our other speakers and all the participants who hung with us. And everything that was posted in the chat will be available after the fact, as in addition to our recording. So thanks to everyone for the engagement, and again, thanks to the speakers today.